So, our next speaker is actually known to us and a friend of mine. And he underwent his fellowship at Rizal Medical Center and further training at Taiwan for liver transplant. So he will be discussing vascular and biliary complications of liver transplantation. Let's welcome Dr. Raymond Joseph Devel.
So good afternoon. I would like to thank the organizing committee for this opportunity to speak in front of you, and it is an honor to be in the presence of our esteemed colleagues and at the same time very nerve-wracking. And again, congratulations to the organizers for the success of this symposium. I have no disclosures other than I have been tasked to lecture this in lieu of Dr. Vanessa Villa, and some of my slides are from her and Dr. And I would like to thank the following and acknowledge them for helping and contributing to the creation of this lecture. Liver transplant is a life-saving treatment that is mainly used for end-stage liver disease, acute liver failure, and in selected liver cancer patients. Improvements in surgical technique, anesthesia, post-operative care, organ preservation, as well as new immunosuppressive medication options have led to better survival rates. However, with increased survival, the number of reported cases, both early and late-stage complications, has increased as well. The rate of vascular complications after liver transplant has been reported to range from 7% to 15%. However, the rate has been as high as 25 to 30% in living donor liver transplant, pediatric liver transplant, and split deceased donor liver transplant. A unique feature of the liver is its dual blood supply by the hepatic artery and portal vein. Liver transplant requires a minimum of 3 and very frequently more than that of vascular anastomosis to establish inflow and outflow to the allograft. An HPB surgeon is considered a hybrid surgeon because he can be a transplant surgeon to do this procedure and a vascular surgeon as well in doing this anastomosis. And mastery of anatomy is crucial. So before we delve into the complications, we should have a clear understanding of the surgical altered anatomy after liver transplantation. So for cadaveric transplantation, usually a whole graft is used. And then for split graft, the right lobe is usually given to an adult and the lateral graft is given to pediatric. And then for a living donor, it's either the right or the left lobe. So this is a slide I borrowed from Dr. Kuhn, and there are variations in the surgical technique of the various anastomosis. So this slide just shows some of these surgical variations, and rarely the graft hepatic artery may also be anastomosed to the external iliac or superior mesenteric arteries. So here are some actual pictures of hepatic artery and bile duct anastomosis during my training in caution time. And this is a diagram by Dr. De Villa, and I just like to show here the portal vein branch patch anastomosis. And another slide I borrowed from Dr. Kuhn, just to show the techniques of hepatic vein reconstruction, either with a IVC replacement or a piggyback technique. So for arterial complications, hepatic artery thrombosis is the most common vascular complication after liver transplant. Early diagnosis and treatment are essential to prevent graft and failure death. Arterial complications can lead to biliary complications and graft dysfunction. A pseudoaneurysm is a less common but potentially serious complication, and it usually occurs within the first 2 months after transplant and presents as sepsis or gastrointestinal bleeding. Most are mycotic in nature, and urgent surgical repair and antimicrobial therapy are necessary. Hepatic artery complications can lead to ischemia of the liver graft, which can result in graft morbidity or graft loss or even patient death. Despite continuous improvement of the surgical technique, these complications still represent one of the main causes of failure of liver transplantation, with an incidence of 2.6 to 20% in adult recipients and about 5 to 10% in children. Hepatic artery thrombosis leads to retransplantation in 50 to 75% of patients, with a mortality rate approaching 50%. Early hepatic artery thrombosis can result in graft loss and mortality if not immediately treated. So, hepatic artery thrombosis may occur early in the post-transplantation period and may lead to the following: and associated bile leak soon after liver transplantation due to the loss of bile ducts' main vascular supply. Acute hepatic artery thrombosis may be treated by attempted thrombectomy. If this is unsuccessful, retransplantation is needed. Hepatic artery thrombosis that occurs long after liver transplantation may produce intra and extrahepatic bile duct strictures and may be an indication for an elective retransplantation. Early hepatic artery thrombosis, when the allograft is devoid of arterial collaterals, results in selective necrosis of the biliary tree and surrounding connective tissue, and occasionally, hepatic artery thrombosis is completely asymptomatic. Predisposing factors for hepatic artery thrombosis most stem from donor and graft features. A high proportion of patients undergoing liver transplantation have liver steatosis and atherosclerosis, or vessels that have been subjected to transarterial chemoembolization in hepatocellular carcinoma patients, resulting in vessel walls that are fragile. This paper enumerated the independent factors for early HAT were donor age greater than 60 years and bench reconstruction of anatomical variants of the hepatic artery. In late hepatic arterial thrombosis, arterial anastomosis fashioned using an interpositional graft of donor iliac artery or an iliac conduit, and donors who died of cerebrovascular accident were found to be predictors. And history of previous orthotopic liver transplantation and also presence of cytomegalovirus infection. The challenges of hepatic artery reconstruction in liver transplantation are related to vessel quality and length. The use of microsurgical technique has helped to overcome the risk of HAT in many series. The use of microsurgical technique, appropriate recipient vessel selection, minimization of vessel manipulation with modified instruments, variation in anastomosis techniques, and the use of radial artery interpositional grafts are useful strategies to maximize the chance of success. For portal vein complications after living donor liver transplant have been a major concern in pediatric liver transplantation. The incidence of portal vein complications is more in pediatric than in adult recipients. Early diagnosis and treatment of portal vein complications may ensure optimal graft function and good recipient survival. Portal vein thrombosis can lead to liver failure and gastrointestinal bleeding, and pre-existing portal vein thrombosis and the need for portal vein grafting are risk factors. So other factors to be considered in terms of portal vein complications are the flow dynamics. Conditions to watch out for are small for size syndrome and the portal steal phenomenon, and these can be evaluated with the use of flow meters intraoperatively. When portal vein stenosis occurs, the patient condition may deteriorate rapidly, presenting with the following conditions. Although surgical thrombectomy may be successful, urgent retransplantation is often necessary. Late portal vein thrombosis may allow normal liver function but usually results in variceal bleeding and ascites. For the hepatic veins, the incidence of stenosis of the hepatic vein and caval anastomosis varies from 1 to 6%. This can be due to rotation of the liver graft or true stricture of the anastomosis. So it is either an anastomotic technical error or progressive neo-intimal hyperplasia, or an allograft positioning error with torsion or compression of anastomosis. A side-to-side cavoplasty reduces the risk of stenosis, and venous outflow obstruction is more common with the PTBAC technique. Although clinical signs and symptoms and laboratory results are predictive in the diagnosis of vascular complications, radiologic tests are vital in diagnosis because they show actual vascular flow. The state of vascular anastomosis early after transplant should be closely followed radiologically. So Doppler ultrasound is a highly sensitive and efficient method for examination of vascular complications and is the primary screening tool for hepatic artery thrombosis and other vascular complications. In a recent study by Nishida and colleagues, daily monitoring of arterial flow with Doppler ultrasonography reduced the need for retransplantation to zero in the presence of early hepatic artery thrombosis in pediatric recipients. For cases of possible vascular pathology or positive findings on Doppler ultrasound, more sensitive and specific methods like CT angiogram and MRA are recommended. So this is how they measure the portal vein and compared portal pressure and compared to the CVP to get the pressure gradient of various stages of the transplantation. This is how they recorded it intraoperatively in Taiwan. For the management, it can be grouped into medical, interventional, and surgical. The following are the medical strategies to help obviate vascular complications. And most transplant centers have protocols of giving anticoagulants intra-op and post-operatively. Options of treatment include endovascular interventions like percutaneous transluminal angioplasty with stent or without stent. PTA is a percutaneous procedure used to widen the narrow blood vessels, and stenting is sometimes done to maintain patency after angioplasty. Surgical options include open thrombectomy, revision and reanastomosis, and in cases of severe irreversible graft damage, retransplantation may be necessary. So it is important to note that the management of vascular complications after liver transplant should be individualized based on the patient's specific situation. So the following slides are various examples and citations of different management of vascular complications. So it is already established that microsurgical technique for hepatic artery anastomosis is superior. The recognition of injuries of the vessel in the intima of the vessel, precise dissections and use of hemoclips to ligate branches are important for successful hepatic artery reconstruction. So this is a modified funneling technique and is an example of a continual technical refinement by the Kaohsiung Changgong team for refinements of their techniques in liver transplant. So for a size discrepancy wherein the discrepancy is more than 1:2, so they anastomose this here, and then the remaining part they just close with the figure of 8 stage, and then they place a hemoclip here obliquely or diagonally to form sort of a funnel. This is a management algorithm while encountering poor hepatic artery flows after anastomosis of the same group. Careful examination of the hepatic artery graft and selection of the appropriate recipient hepatic artery are key to successful anastomosis in living donor liver transplant. And immediate redo hepatic artery reconstruction is carried out while the flow is less than 0.3 meters per second. So the right gastroepiploic artery is the most adapted alternative to replace a pathological hepatic artery. And other options are radial artery graft interposition or iliac conduits. Portal vein angioplasty or stenting is conventionally performed through the percutaneous transhepatic approach. However, this can also be performed through transjugular, transplinic, and intraoperative approach. Depending on the situation, using optimal method is the key point to minimize complication and gain high success rate. Good patency, as high as 100% with self-expandable metallic stents, was noted in long-term follow-up of this paper. And they concluded that the portal vein stent placement is an effective long-term treatment modality to manage portal vein complications after pediatric living donor liver transplant. In this paper, they enumerated various conditions that could be predictors of portal vein complications such as portal vein stenosis or thrombosis, mostly in the pediatric population, usually in patients with biliary atresia. So a small portal vein size of less than 4 mm, a slow portal flow, and hepatic artery resistive index of less than 0.65. This is one of the innovative techniques where they access the portal vein anastomosis via the P4 stump. So this is a left lateral graft, and this is the ligated portal vein pedicle to segment 4. So they insert a catheter here, and then with angiographic assistance, they insert the self-expanding metal stent here, showing the discrepancy from the graft coming from an adult, large size, and a small pediatric mean portal vein. The use of intraoperative portal venography to detect spontaneous portosystemic collateral vessels and evaluate the portal vein anastomosis has been described in adult living donor liver transplantation. This paper reports 2 cases in which this procedure was used to guide intraoperative portal vein stent placement through the inferior mesenteric vein approach and with the use of the stump of the segment for portal vein. So the use of stents to correct size mismatches or acute angulation at the anastomosis may prove as effective or more effective in treating small-sized native portal veins and may carry less risk of warm ischemia to the graft rather than surgical revision of the anastomosis. Here is a very complex case and a good example of several vascular complications after liver transplant. So during our time there, this patient was 22 years old already and with a chief complaint of recurrent GI bleeding. So he underwent living donor liver transplant when he was 1 year old with a left lateral segment graft for neonatal hepatitis. The portal vein reconstruction was performed using end-to-end anastomosis of the native portal vein branch to the left portal vein. So the patient experienced several post-transplant complications such as septic shock secondary to biliary tract infection, which was managed conservatively. And at 44 months post-transplant, or around 5 years old, he underwent small bowel resection due to intestinal diffuse large B-cell lymphoma from PTLD and received adjuvant chemotherapy. At 13 years post-transplant, he had recurrent variceal bleeding due to portal hypertension from the main portal vein occlusion. He underwent endoscopic therapy and splenic artery embolization. A percutaneous transluminal portal vein stenting was attempted but was unsuccessful. So portal hypertension decompression surgery was performed where they did an inferior mesenteric vein to femoral vein shunt using a Gore-Tex graft. Unfortunately, there was early shunt thrombosis. Hence, they did a partial splenectomy combined with distal splenorenal shunt to decompress the portal pressure. Similarly, this second shunt failed to achieve long-term patency. So subsequently, he experienced increasing frequency of gastrointestinal bleeding, and capsule endoscopy showed jejunal varices for which hemoclips were applied. However, bleeding recurred despite this intervention, and after a comprehensive multidisciplinary team planning, the authors performed an innovative surgical alternative to the Mesorex bypass in this post-LDLT patient with extensive postoperative adhesions, perihilar collaterals, and cavernous transformation. So this image shows the prominent perihilar collaterals and cavernous transformation, and the large collateral pointed by the yellow arrows, large collateral of SMB. So, an ultrasound-guided transhepatic puncture to the transection plane of segment 3 and cannulation of the umbilical portion was done. And a covered self-expanding metal stent, Gore Viaband stent, was deployed with the distal end inside the umbilical portion and the proximal end connected to and deployed within a gel soft Terumo graft, and then this graft was anastomosed end to end to the large SMV collateral. So the two synthetic grafts had a snug and secure fit. So this is the angiogram showing this is a puncture to the graft, and then showing the large collateral connected to the gel soft graft. And then within the gel soft graft is the deployed metal stent, and the other end of the metal stent deployed into the umbilical portion of the umbilical vein. This is a angiogram 14 days post-op, and this is a CTA 10 months after the surgery showing patency of the vein, and Doppler ultrasound at 19 months, showing patent intrahepatic and portal vein with normal flow and waveform. So this is another case to demonstrate the complex portal flow dynamic. So this is a case of a 53-year-old female Malaysian lady with primary biliary cirrhosis and repeated variceal bleeding. She had a MELD score of 15, Child-Pugh score of C10, and UNOS 2B. Her CT angiogram showed liver cirrhosis, splenomegaly, portal vein thrombosis, and two large portosystemic collaterals shown in this upper left picture of a large coronary vein, 10.9 millimeter, and here is a large gastrorenal shunt, 11.6 millimeter. The donor was the patient's husband and was ABO incompatible with a marginal left lobe graft volume to receive marginal left lobe graft volume. The estimated volumetry was 35% by CT scan, but the actual graft, however, was smaller than the CT estimate with a weight of only 284 grams or 31% of standard liver volume and a GRWR of 0.73. After the reperfusion, the portal pressure gradient was only 7 millimeters mercury, while portal vein velocity and portal flow volume were increased. In order to avoid early graft dysfunction and or small for size syndrome, a decision was made for staged surgical ligation of the portosystemic collateral, and the large portosystemic collaterals were intentionally left patent in order to allow for initial graft regeneration prior to subsequent portosystemic collateral ligation to prevent future risk for portal flow steal syndrome. This was decided for the patient since she was from overseas and close follow-up with frequent Doppler ultrasound and CT imaging was logistically not feasible. So 1 month after repeat CT scan, it showed adequate regeneration to more than double the original graft volume to 634 ml, and they proceeded with the ligation of the collaterals. So this slide is courtesy of Dr. Kuhn during our training there. So these are some actual cases where the dilated gastric varices were accessed by a transhepatic approach into the portal vein and into the left gastric vein. And the varices were coiled using the detachable coils followed by glue lipidol embolization. So for outflow, this paper describes addressing multiple outflow of the living donor graft. So they do this two outflow of the right hepatic vein, and they did a graft septoplasty. They made a slit here in the connecting membrane of the vessels, remove some of the parenchyma and anastomose it as such, so that there would be a single common orifice. This is another paper, series of the previous one where they did the same, where they do venoplasty to make a common outflow channel. So this is another complex case, all-in-one sleeve patch graft venoplasty for multiple hepatic vein reconstruction in living donor liver transplantation. So this liver graft had multiple outflows, two from segment 5, two from segment 6, and the main right hepatic vein. So they used a cryopreserved iliac graft and opened it up and anastomose it to the two segment 5 vein, and then this patch was anastomosed to the recanalized umbilical vein graft of the recipient. So this is an example of the complex outflow anatomy of the donor, and they anastomosed all those outflow into a single patch. And this single patch was anastomosed to the side to side to the IVC. So this is another case of a 5-in-1 outflow recon that I actually saw during my stay in Taiwan. So the pre-op CT scan showed the multiple hepatic venous drainage, and the same technique was employed using a iliac Y graft, and the same anastomosis to the vena cava was done. So to briefly touch on biliary complication, biliary reconstruction has always been regarded as the Achilles heel of liver transplant. Biliary complications in LDLT are often attributed to technical difficulties due to small size and multiple ducts. Biliary complications in liver transplant have been described to be more frequent in occurrence than in deceased donor liver transplant. In pediatric liver transplant, biliary complications in children who underwent LDLT were almost doubled compared to those who underwent deceased donor liver transplant. However, with broadening experience, the initial 15 to 20% biliary complication rates have been reduced to 4 to 6%. Non-anastomotic complications are commonly preservation, ischemia, and reperfusion injury related and usually manifest as late complications. Microsurgical techniques initially used for hepatic artery reconstruction have been extended to biliary reconstruction to decrease biliary complications. And their paper shows the improvement of their technique as they acquired more cases. And it's clearly shown the decrease of their complication in the microsurgical group. So analysis showed that conventional reconstruction increased the risk of biliary complications by 2.4 times. And the routine use of microsurgical biliary reconstruction in pediatric living donor liver transplant is a technical innovation that led to decreased anastomotic biliary complications. For some local experience, this one is a report by our very own Dr. Paloyo and the KTI team. This is a case of a metabolic dysfunction associated fatty liver disease wherein a jump graft of PTFE was used as a hepatic artery reconstruction from the external iliac to the donor celiac artery. And this is the diagram showing the connection from the iliac to the celiac artery of the graft. This was done because of the poor condition of the recipient's native hepatic artery. So this 2 months later, he presented with hemophilia and imaging showed the presence of a pseudoaneurysm. And this was addressed by deploying an endovascular covered metal stent, occluding the pseudoaneurysm as confirmed by this angiography. So the patient was maintained on prolonged antibiotics with no recurrence of hemophilia and stable graft function at 6 months of follow-up. The following are the cases of our very own Dr. Vanessa De Villa at the Medical City Liver Center. So this is a case of a hepatic artery thrombosis. So this image, this is a celiac trunk angiography showing no flow to the liver graft. And then on thrombolysis and they achieved reperfusion of blood. And for the venous outflow obstruction, this is done through the transjugular. So here it can be seen that there is a very nice image of the hepatic vein, but no outflow. So because of the outflow obstruction, there is a congestion of the liver as shown by the lighting up of all the tributaries of the hepatic vein even to the smallest radical. So this stenosis was dilated with a balloon, and upon balloon dilatation, you can see that there is already outflow here. The hepatic vein. So this is a diagram of the vascular reconstruction in a 2-year-old female with biliary atresia. And the complications here is, this is the patient's IVC. They had the stenosis because of a use of a stapler that was a larger stapler load, because that they had yun lang yung available. And so they did a balloon dilation of that strictured part. And here is shown the resolved stenosis. And in the same case, there was also hepatic outflow obstruction, as again seen by this congested graft. See, you can also see the small tributaries of the hepatic vein. So balloon dilatation was done and outflow was achieved, as seen here. However, 1 month there was still a residual stenosis, and further balloon dilatation showed resolution with the patency, achieving patency of the outflow. So the next is a 40-year-old female with end-stage liver disease secondary to chronic hepatitis, and the complication that we want to show you is here's the portal still. So in this imaging, this is the main portal vein with the cut-off here, splenic vein and SMV. And this video shows the direct portography showing, so the flow of the contrast should be going here to the upper left corner to the liver graft, but instead it goes back to the splenic vein. So this is the portal still phenomenon. So this one was successfully dilated and stented. And this is just to show the intricacies of the vascular anastomosis of the portal vein and hepatic vein done by our very own Dr. Barroso. So this is after the anastomosis of the portal vein, and they're removing the clamps, and then followed by the hepatic vein. The hepatic vein and then followed by the portal vein to check for bleeding. And this is to show the importance of employing various tools to evaluate the hemodynamics of the graft flow with intraoperative ultrasound, with Doppler, and with transit time flow meter or TTFM. So this is an algorithm from the manual of the TTFM machine and gives a certain values in assessing the flow. So in summary, vascular complications after liver transplant can be lethal, and high levels of suspicion and aggressive use of diagnostic tools may help with early diagnosis and treatment. Recipient vessel selection, radial artery interpositional grafts, selective vessel manipulation, and variations in anastomosis technique are useful strategies to maximize the chances of success. Because vascular complications are the most severe complications after liver transplant, there must be close follow-up of vascular anastomosis, particularly early post-operatively with radiologic methods. And in case of vascular complications, emergent treatment, including endovascular intervention, surgery, and retransplant must be performed. Thank you.
Thank you very much, Dr. Raymond De Vela, for a very excellent lecture. So, any questions from your dad? So, may I invite na lang Dr. De Vela to give the certificate? Kita ko umiiyak si sir. Proud dad. Sir, certificate of appreciation is awarded to Dr. Raymond Joseph De Vela for his invaluable contribution to this symposium. Thank you. So our next part of the is the research and video contest. So pahinga lang na konti kasi the next moderator is actually RG De Vela.
Thank you very much to our moderator, Dr. RJ Romero. Thank you. That ends our extended morning session for today's program. While we proceed to the afternoon program, we would like to remind again the participants to please answer our evaluation. So the QR code is projected in front. And again, we will take this opportunity to invite you to our fellowship night, which will happen tonight at 6 p.m. Same hotel, it will be at the roof. That's the name of the venue. It's at the top floor of Joy Nostalg Hotel and Suites. And also, please, you still have time to go around our exhibit hall, have your bingo ticket signed. And if you weren't successful to bring home prizes yesterday, today might be your lucky day. So we have bigger and more exciting prizes. So Please don't forget to drop your